Puneet Dhar sir for his talk on can immunotherapy or chemotherapy cure HCC.
You've been promoted an oncologist, Puneet.
Yeah, two disclaimers. Yeah, I've not changed my profession, and I'm still friends with Baiju for giving me that topic.
So we are glad it's a surgeon rather than an oncologist.
So I bring you greetings from Amrita, outside of Kerala. Lovely campus. Please visit it if you're in Delhi. So I think the issues we're all familiar with, the high incidence of cancer-related death, particularly in the Afro-Asian countries. Since it can be frequently asymptomatic, the metastasis and the background can be in liver disease, the metastasis and recurrence is common. So there's an important need for systemic therapy in a wide variety of patients. There's several. Flip side is that there are several signaling pathways which are dysregulated and can cause uncontrolled cell propagation, metastasis, and recurrence. So the mainstay, of course, is resection, transplant, ablations, and other liver-directed therapy. But a large proportion may not be amenable to these. Unlike a lot of the other tumors, the basic tumor microenvironment itself is immunosuppressive. So it's a tragedy that, a large proportion are actually preventable, both the HPB and as it's going down, the metabolic associated HCC. So the potential targets are wide and many, and I'm not going to run you through that. Vimlakar, I think, said it's a lot of, most of it used to be tyrosine kinase, but now newer stuff is coming, particularly the immunotherapies. So, I mean, if you see in the last 2 decades, it was only sorafenib for the first decade, from 2008 till 2017. But in the subsequent decade, you can see the number which actually have been investigated and found to be actually useful for a large proportion. Now, the question Baiju had is whether are we ready for cure? Well, clearly, knowing how quickly the hall has got emptied, surgeons don't like such charts. So clearly, the easy answer is no. But I think the direction all this is taking, I think it's important that when we go to the tumor board, we don't hang our heads and we look like Sudhi, we understand that we know all what we're talking about. So, and even a large proportion, the orange bits in the lower one is in the 5 years, is all phase 2 studies. So, and a lot of phase 3 has also been, come out. So, so since we're familiar with tyrosine kinase, I won't tell you anything about that. But I think immune checkpoint, ever since Honjo and Allison got the 2000 pre-COVID Nobel Prize for Medicine and Physiology, it was specifically for this. Allison actually worked on the cytotoxic T lymphocyte associated antigen 4, and the Honjo worked on the programmed cell death. So basically, it has this PD1, the programmed cell death 1, the receptors on the T lymphocyte, which acts as a regular brake for the immune system, so it doesn't run amok and cause self goals to prevent harm to healthy cells, and yet be able to, when required, when activated, the cytokine activation and all that, to be active as an immune self-immunity against the tumor. So the PDL1, the programmed cell death ligand, is expressed on the cancer cells primarily, and when these two combine, you get an immune checkpoint. So this is where the T cells are actually, that's a diagrammatic version of the same thing. So that is the T cell. And when they combine, all this happens. So it actually prevents the T cell from doing its job. And so it runs, the cancer can now proliferate, metastasize, recur, whatever you. So the inhibitors of this immune checkpoint block this interaction of the PD1 and the PDL1. So it's one of the mechanisms is the PD1, PDL1, and the second is the CTLA4, the cytotoxic T lymphocyte associated 4 antigen. And they allow the immune system to target and destroy cancer cells. So I think it's important for us to understand this, because in other areas also, we are now seeing organ preservation as well as in rectal cancer. I think one has just come out in NEJM again on rectal cancer, I think today itself. So the current iteration of NCCN guidelines already shows a variety of these already based on, so I won't run you through this. I just want to tell you the basis, because so that we start thinking about it, so that when, as and when it becomes better, more usable, we are all on top of things rather than, going, especially since this happens and sometimes in cirrhotic patients whom we're not so excited about doing liver stuff on them. So the first of these, so basically the first preferred regimes. So this is atezolizumab with bevacizumab, which is a VEGF inhibitor with the immune therapy. The combination of the two actually was shown in this trial, a global open phase 3 trial, who had never previously received systemic therapy, that they had better overall and progression-free survival outcomes than sorafenib. So all these are comparing with sorafenib, which till then was the, sort of the one studied for the longest time. So definitely better outcomes in the unresectable setting. And that's why it came into the NCCN guidelines as well. But, for us, important is the next. So overall survival at 12 months was an impressive 67.2. So no cure as yet, but probably we could get there at some stage. The same combination actually was subsequently tried and about a year and a half back came online in the high risk hepatomas as adjuvant therapy. And this is probably, again, it was a global only for high risk surgically resected patients. A definite recurrence-free survival is improved. And so I think the first phase 3 study of an adjuvant treatment for hepatocellular carcinoma to show positive results. So I think we need to, as surgeons do need to get to know, it's not an exotic topic any longer. The second is the follow-up to the Himalaya study, which was, early use of the tremelimumab with the durvalumab. Durvalumab, I think, is coming up in a big way. Even on Nilesh's thing, I think there is some evidence about durvalumab as well. So they went ahead with this, timely STRIDE study. That is a single dose of tremelimumab along with regular interval durvalumab, which significantly improved the overall survival again versus sorafenib, as well as durvalumab. So single agent, these were three arm. So the combination did better than either sorafenib or durvalumab, and both those were actually equivalent to each other. No non-inferiority. So I think we need to watch this space, and 36 month survival is again about 1/3 of patients. And then we come to now this field is changing every single day. This is published just 2 days back. If I'd listened to, Baiju and not come up with uploaded the slides, I would have missed this study. So this just, day before yesterday uploaded the combination of nivolumab and ipilimumab versus either one of the multikinase inhibitors as first-line treatment, and again showed overall survival benefit were either of those angiogenic inhibiting multikinase inhibitors. So again, this is coming to first line. Funnily enough, this is actually already been suggested in the NCCN, but now we have hard data for that. Second is basically a Chinese study, the Apollo group, which is anglotinib plus penpulimab against sorafenib, again as first line, and showing definite improved progression-free survival and overall survival. This is also published just day before yesterday, and might be a new first-line options. Now, which of these, since all of these are compared only with sorafenib, I think the first two have been the standard of care since we have longer duration. I think, again, just like FLOT and MAGIC and all that, it's going to be the kind of toxicity tolerance that we have. The two combined, the CTLA4 and the PDL and PD-1 antagonists, they tend to be more toxic. So I think we could use those for the better risk patients. So, but I think this space still needs to be. So I just want to give a brief outline of what is available. The variants are also important because in the post-liver transplant setting, we avoid immunotherapy because there's much higher, organ rejections. So you still have to, despite the toxicity, we have to give the multikinase angiogenic inhibitors, plus probably mTOR inhibitors, rapamycin and all that will be useful to prevent the tumor recurrence. The neurotrophic tyrosine receptor kinase fusion positive tumors, these are very rare tumors, but if they're there, if these are expressed, they have a very good and sustained response with the tyrosine kinase inhibitors, all the trectinibs, the larotrectinib, the entrectinib, and the repotrectinib. So definite there in case it is there. Second line also we have availability. That's why we need to know that these are available. Most of these are all for child A cirrhosis. So we can use lenvatinib. The second line after a multikinase inhibitor, we give again the same ipi-nivo combination or pembrolizumab as a single agent. If the AFP is high, then ramucirumab is actually, probably much more useful. So some kind of, personalization, I think we're going to see that in the next few years. And I think we need to be on top of that as well. So long as you can pronounce all of these and, say, give a familiar nod, my job would be done. For the child B patients, the single agent immunotherapy agents are probably the best as of now, if the patient can tolerate it. So, but we, the last ASCO, we're lucky the ASCO is still a month away. Otherwise, you will have a few more tongue twisters to deal with. So, we are going that route where we have, going towards the personalization. To summarize, systemic therapy, especially combinations of immunotherapy or with the anti-angiogenic multikinase inhibitors, has got to be already the first line in unresectable. Is starting to be early indicators of an adjuvant role, and classical targeting is yet to be achieved. Even sorafenib is not specifically tyrosine kinase like imatinib and all that. It is multikinase, multiple. The anti-angiogenic effect is also there, which is good in HCC because there's a large part of it is the vascular proliferation part, which is involved in its spread. So there is still a possibility of cure in the future, but we're not there yet. So we still have to be, like this king vulture, be very alert and not bury our head in the sand like the ostriches, and be aware of all that's there. Thank you for a patient listening.
Thank you so much, sir. Sir, regarding the use of immunotherapy as a neoadjuvant before transplant, how is the data evolving? Is it really worth it?
So neoadjuvant, there hasn't been much. Those have been at that particular study which showed that combination as being effective has been adjuvant only. So, but unless we start thinking about it, we're not, it took us a long time after Magic also to switch to, and now we're all talking on the same page. So I think it's important that Baiju kept it. I thank you. That's why he's still my friend, because I was actually cursing him for giving me this topic. But when I read up about it, I didn't realize that so much is already done. So I think unless we start thinking about it, we're not going to reach the neoadjuvant space. Even for CA gallbladder, we took a long time till the Tata data came out. Sorry, you want to say something?
Sanjay. You're gone, please go.
I just want when you said that
Can somebody give a mic, please?
yeah. So you said that you won't give atezo-bev for post-transplant recurrences of
The
age.
immunotherapies.
Immunotherapy.
Yeah.
So just to say that has changed quite significantly.
Okay.
So from the last February, there was a consensus conference which I attended for for cancer management and transplant.
Post-transplant.
For basically guidelines for cancer in relation to transplant. And there are many unpublished series of more than 50, 60 patients who have been treated with atezo-bev for post-transplant recurrences. We have done 2 patients and it's not a problem.
So there you go. So we learn continuously. I remember when we gave the combination of in Hep B, the combination of those 2 drugs, people laughed at us in the Cochin Gut Club, and later that became the standard of care.
No, but there's this thing, it does increase the risk of rejection. And therefore, what you have to do before you start it, you have to up the immunosuppression.
Yeah. So
the general principle when you get a recurrence is to cut down immunosuppression in these patients. But in this situation, you build up the immunosuppression again, maybe start them on about a 5 milligram dose of steroid, and then...
So since a large proportion of these immunotherapy patients get toxic effects enough to need steroids, probably transplant is one place where, I can see where that's going. So it's possible that you can get the benefits of both. Absolutely. So I think unless we try it, we're not going to...
So Sanjay, actazolizumab was given? I thought it was nivolumab only.
No, no, no. Atezobev has been given.
Really? Okay.
There is a big, is it Kim Watt? Kim Wyatt or Kim Watt from, she's a hepatologist from Mayo. And there's another big series from Mount Sinai where there's a Armenian girl whose name, lady, hepatologist, whose name I can't remember.
So actually, to be honest, I only looked at the phase 3, phase 2 data. I didn't look at all the others because there was such a huge, I never realized there was such a huge, thing waiting to, so 7 minutes, I didn't even think I would read that much. So, yeah, but it's good to know that it's
Do you know the level of AFP for Ramesh? Ramesh is just a VEGF.
400. Yeah, if it's more than
VEGF,
400.
So why most of them have high AFP anyway, no?
So, I mean, I'm not sure the reason, but not really sure why. You have any suggestion why?
No, I don't know. Because it's just a VEGF inhibitor. So. Anyway, thank you very much. Puneet, that is. Any other questions? Or yeah,
Ramesh.
The two questions by the side. How do you actually remember all these spellings?
How do you
Number one,
remember?
the spelling of all these things.
So it's very interesting, actually. If you look at these, the names, all the MABs have a very interesting background. So the last three is, of course, MAB, so monoclonal antibody. The one before that is
ICSU is
so either chimeric or lymphocyte derived or
Oh, yeah.
tumor derived. So you can actually figure out, and the first
Whatever-
three will tell you what it starts. So infliximab inhibits necrosis factor. Li is the lymphocyte derived. The Xi is the chimeric. So actually you can figure out what it was used for first.
And when do you think the cost is going to come down?
Sorry.
When do you think the cost is going to come down? What is your
So
prediction?
that's a very, very good point that he said. So I can just tell you, like ulcerative colitis 10 years back, infliximab and all used to be in lakhs, and suddenly now it is in thousands. So I think it's only going to be used since it's so much of use in LMIC, low and middle income countries. I foresee that being much faster, and we are also at the cutting edge of the pharma research. So I think it's going to be much faster than we
It's
imagine.
going to be
So
very
I think it's
quick.
important that Indians start using it. Yeah.
It's going to be pretty soon because just 2 weeks ago, my mom is the reason I'm saying it with so much confidence is that she's on Indian Cancer Society chairman. And she was in a meeting with Rajya Sabha, and the government is planning to cut down costs. So they called a whole lot of people to try and work out how to reduce costs for this. So it is coming.
So since it's commoner here, I think it will happen faster. And I think that latency has come down dramatically now.
For the spelling, no? All you have to do is just do all M's.
Thank you, Puneet. Thank you so much.